Hello and welcome to Newsclick. Today we have with us Dr. Satyajit Rath from National Institute of Immunology, and we will discuss the recent case which has been reported widely about this AIDS cure for an infant or a baby. Satyajit, if we look at the details of the case, what does it signify in terms of public health or in terms of a scientific breakthrough?
So it's interesting that what the case says much more about is the level of anxiety that we have about HIV as a public health problem and about HIV as a medical problem in the sense of a problem of individuals. This is despite the fact that worldwide infection rates are dropping, in some places more rapidly than in others. And yet, HIV is one of those infections that we treat as a little bit like cancer. Once you are infected, it never goes away. You are stuck at best with therapy for the rest of your life. This is very unusual for an infection. It's fairly common in the cancer field, but it's very uncommon in the infection field. So the case is essentially, I think, the second documented case of apparently cured recovery from HIV infection.
The first was the bone marrow transplant,
the first
the
was
specific immune genetic modification that it, or what was already existing.
The first was actually a straightforward case of very radical treatment for leukemia, followed by a bone marrow transplant, and in the process of which it's possible that almost as a byproduct of the radical treatment, the virus and the virus carrying cells were eliminated. It's known as the Berlin case.
Yeah, but also because there was already a specific gene which was there in the donor, which is found to have some protection against HIV.
Correct. That's correct.
So therefore, there was also the specific case, not only just simply a bone marrow transplant, but also of this.
That's correct. Although, as we will talk about in the present case, even in that case, there is really no evidence to say that that did play a role or that it didn't play a role. And this is, in a sense, the limitation with all anecdotal single case situations. Consider the case of this baby in Mississippi. The mother was discovered to be HIV positive at so late a stage that, unlike what is current practice, which is that all mothers who are during antenatal care diagnosed as being HIV positive begin to receive antiretroviral therapy, and the babies get maintenance antiretroviral therapy.
And also cesarean section so that during birth you're not infected.
Yes. Now, in this process, transmission rates from the mother to the baby can be cut under ideal situations from something like 40% to somewhere around 2 or 3%. That's very substantial reduction of successful transmission of infection to the baby. Unfortunately, this was a situation where nobody knew that the mother was infected until she was delivering the child. So there was no way of putting the child onto antenatal retroviral therapy. So what do? You take a blood sample from the child and you wait for the diagnosis. Do you start therapy immediately? On a baby, particularly, although I don't know about this particular case, particularly because commonly with mothers who are HIV positive, who are at some stage of the disease, babies tend to be born not in an ideal state and condition, quite commonly. How does one decide how much of retrovirals to give? Does one give the entire complement? Does one give only one? Does one? All of these are very uncertain calls. So Dr. Hannah Gay at the University of Mississippi, who was the primary physician on this matter, made a decision. She decided that the mother's HIV and the lack of antenatal therapy was so serious a risk for the baby to be positive that within the first day or two of being born, the baby was to be put on a full anti-HIV drug regimen.
3-drug cocktail.
These are toxic drugs. They're not easy to take. Even for adults, they're not easy to take. For babies, particularly babies born not in the best of conditions, they can be quite problematic. So, these are not simple calls for the physician or the family to make. Nonetheless, they made it. Now, the interesting thing is that the initial blood samples from the baby, which are typically taken from the umbilical cord blood, they came out as being HIV positive. So, officially, the baby is declared as having been infected before drug therapy began. Now, you can always say, what exactly does being infected mean when the sample is taken at that stage? And we'll come back to this in a minute. What they did was continue with therapy. At the end of a month or a month and a half, virus levels in the baby declined, as is normal for many of these kinds of situations, to the point that they were barely detectable or undetectable. Therapy was continued. And then, a few months later,
18 months later,
the unexpected happened. Now, again, this is something that was done, what in Indian hospitals is called AMA, against medical advice. In effect, the mother simply stopped therapy for the baby. So, a few months later, Dr. Gave, through a variety of circumstances, retraced the baby. And before she restarted the baby on therapy, drew a blood sample to test, fully expecting that the baby was going to have a resurgence to some extent of infection. The baby doesn't have infection. Now, this is the sum total of what everybody is getting excited about. That it's not prevention, because prevention would be prevention. And we know about prevention cases. It's cure. Why is it cure? Because the baby was infected before drug therapy started. How do we know the baby is cured? Because we withdrew treatment and discovered that the baby stayed negative. Are we actually ethically permitted to do that? Are we ethically permitted to withdraw treatment? Nobody's quite sure.
Answer is really no.
The answer is really no.
Doctors have said that we should continue, nobody should withdraw, etc., etc.
Correct. But the field is so much of a shifting morass in many of these ethical issues that with this one case, it's possible that trials will be initiated to do this. And we'll find out. The difficulties, the scientific difficulties, are not trivial. So, in the first place, while the baby is being born or just after the baby is being born, you're sampling umbilical blood. So, when the baby is born, the placenta will separate from the uterine wall and there is inevitably a fair amount of bleeding. The bleeding comes from both the fetal and the maternal sides, because the placenta is a composite of the mother's tissues and the baby's tissues. Some amount of blood transfer can in theory happen into the baby's circulation. It's not particularly prominent if you simply look at what percent of the umbilical cord blood is the mother's blood. Very, very, very small percent. But if the mother's virus titers were to be very high, then even an extremely small bleed of that kind with sensitive tests can make it look as though there is virus. And there is certainly virus, but whether that virus has infected the baby's cells, whether that virus has established itself as a latent infection in the baby's cells, because with HIV, latency is the major issue.
It goes into reservoir cells.
Where it goes into quiet reservoirs, from where it can come back under appropriate circumstances appropriate to the virus and inappropriate to the individual. We don't know whether what has been done is simply catch the infection so early that it was almost like prevention, or whether this is a matter of a very specific cure. Whichever it is, the fact of the matter is that these are unusual situations for anybody except babies. Infection is usually by sexual contact, and it's impossible for individuals to say when they were exposed and infected. And therefore, to be able to catch infection in these very, very, very early days is possible, even in theory, only in the situation of the baby.
So it remains a bit of an oddball case, if you will, because if, for instance, we know the mother is HIV positive and we have the ability then to give medicine, we would really do it well before labor has begun. And if we do catch it at the stage of labor and then we have to take action, this in fact could be done in very few places. And if they're already there in such places, the question is, why has antenatal care not been given?
Absolutely.
And those cases where already patients are being born, or children are being born, babies are being born with such infections, it's unlikely that we will be able to give this kind of treatment. And this is about, I'm told, about 400,000 plus babies in Africa. I'm sure about 50, 60,000 babies in India, possibly, who are all, they have to be caught at that stage to have a public health implication. So in public health terms, the respected procedure, which is give them antenatal care and catch with the public health system, catch this kind of cases early enough, would still be the dominant mode of...
Absolutely, which is why I said it right at the beginning that there is an interesting public health issue about this. From the public health point of view, prevention is already working where we implement it. The real issue is, do we have the will to implement prevention through antenatal care that includes anti-HIV treatment to everybody who is in need? And our current situation is that we are not doing this well, even by the WHO's own numbers, the kind of numbers that you quote. The WHO's conservative numbers are 300,000 babies born a year, mostly in the developing world, with or at severe risk of infection. For them, and for them only, is this kind of an approach likely to work from the medical point of view. For the adult sexual contact mediated therapy, it's likely not to be terribly significant. On the other hand, from the public health point of view, we already have, in a sense, a better solution for the babies, which will involve antenatal care, which will involve all the support that the antenatal care provides, independent of the HIV infection, as well as HIV therapy, as well as a non-emergency approach to the problem of the mother and the baby.
So in essence, public health terms, this really has very little significance if we look at the gamut of issues involved. In scientific terms, what we've discovered is if we can catch an infection very early, then antiretroviral therapy may mean the ability to achieve what is called a functional cure. How useful it is a different issue. But would you say that at least that if we catch the infection very early and hit it very hard, as the general practice in AIDS in any case is, then if we catch it very early, then we have a possibility of a functional cure? Or is that remains to be still seen?
Well, certainly from one case, the only thing one can say is it remains to be seen, but it does create that possibility. But let me, having done a certain amount of de-hyping, let me make a point of interest to the larger HIV-infected adult community, where, as we said, since there is no real way of catching the infection very early post-exposure, this particular kind of approach may not really be of great significance. However, here's the issue. If we can work out in structured trials, I have already underlined the many ambiguities and difficulties of the structured trials, but even so, in structured trials, if we can work out what the detail of the stage and level of infection is at which a cure is possible. For example, that certain kinds of cells being infected still allows for cure, but certain other kinds of cells being infected does not allow for cure. Or that a certain kind of viral entry into cells in latent form does not allow for cure, but a certain other one does allow for cure. Then what we have the ability to do is to take people who have been, as adults, infected on retroviral therapy for a long time and ask the question in them, are these categories of, do they have infection in this cell type versus that cell type? Do they have an infection of this kind versus that kind? If we investigate that, then maybe, just maybe, we may be able to distinguish between people who have been on antiretroviral therapy for a long time, who actually don't need it anymore, who can actually be declared or at least tested for cure, versus people who continue to use it. That may not be a small thing if the analyses and the trials going on from this case give us any such leads and clues.
So, given the bleak scenario till now of AIDS cure, at least a small sliver of hope, if you will, for those who may have been cured, but the current medical practice is not to recognize it and treat them for life, maybe some of them can go off antiretroviral therapy. That's the possibility.
We come round to where we began, that the hype around this case and even the non-hyped conversation around this case is really a reflection of the sheer difficulty of HIV, both as a medical situation and as a public health situation.
Thank you, Satyajit.
Thank you very much.